All right, our next speaker is Dr. Jamie Robinson, who comes to us from California today. He is the Kaiser Permanente Distinguished Professor of Health Economics at the University of California, Berkeley. And Jamie and I didn't have a chance to meet until we met the first time last night, and it's kind of hard to imagine, but of course I feel like I know him because he has, I believe it is 85 different publications, and I feel like I know you from your research. You know, he's published in all of the top medical journals, New England Journal of Medicine, Journal of the American Medical Association, as well as the top health policy journals that we see around the country. And so his work has had a tremendous impact on the discipline. And what is so impressive about Jamie is that he really gets out there and he interacts with the health insurers, with healthcare providers, and different medical device and pharmaceutical companies. And he's actually, he won't be talking about that today, I think, but what he's doing in California, I'm hoping that we can duplicate here in Texas. He's actually pulling people from all these different parties. So he's got insurers and healthcare providers and physicians sitting around the table to try to find locally in California what are the most cost-effective ways to improve the quality of healthcare that the California patients receive and to hold down costs at the same time. And I think these local movements where you get everybody to sit around the table are probably going to be the most effective, some of the most effective means things we can do in terms of getting higher quality and lower healthcare costs. So, but with that, Dr. Robinson has come today to talk with us about Pay-for-Performance.
Thanks, Vivian, and thank you to the larger institute for sponsoring the symposium and inviting me out here to join you and share some of my thoughts and have dialogue on the broader issues of healthcare reform. And the topic that I'm going to be addressing is the use of payment methods to influence physician behavior and, more broadly, the trajectory of the healthcare system. And you know, scholars tend to spend our time studying what other people do and talking about that. Today I'm going to give a somewhat different kind of a talk. It's because it's going to be really more about participant observation of a project that I personally have been involved in over the past couple years and still maintain involvement in through another activity that I'm participating in. I'm on the board of directors of an organization in California called the Integrated Healthcare Association, which is an organization that has the leading insurance companies, hospital systems, and medical groups in California working on areas of mutual interest. And one of the projects that we have been engaged in over the past 5 or 6 years is the Pay-for-Performance project in California for the commercially insured population. And we had a lot of experiences there, a lot of learnings, made some mistakes, hopefully learned from some of those mistakes. And so I want to share with you one aspect of that in the hope that there's value in those lessons, both for your thinking here in the medical industrial complex that you all live in, as well as for the broader U.S. experiment issues right now about healthcare reform. And the topic I'm talking about is, well, let me just give you my, first of all, so I want to say my little disclosure statement. This is not any kind of arm's length study. This talk is based on a paper written by myself. My two, do we have a shadow on that, or is it just from this angle? My two co-authors, this is about the IHA experience. We are the IHAs, by the executive director, the head of Pay-for-Performance, and myself. So this isn't some sort of an objective evaluation of anything. It's our war stories. Okay, so I want to talk about the thinking of the transition in Pay-for-Performance from an exclusive focus on quality to value, and what does that mean, efficiency. So give a little description of how Pay-for-Performance works in California. Talk then about the episode of care as the unit of measurement and payment. That's of course interest right now because all the right-minded people from the president on down think that episode payment and episode this and episode that and bundling and all of that is the way to go. And we agree with that, but we've had a lot of difficult problems with that. And we'll talk about those. And we've been backing away from some of that. And then I'll talk a little bit about where we might be going. Okay? And also, I do like to say that I guess the format here is a little bit speaker speaks, and then you guys come up and talk at the mic. But if someone has a question or something as I'm going along, I'm always open to just ask a question or make a comment. Either come up to the mic or just raise your hand. I'm a college professor, university professor. I can deal with people in the back yelling at me. It's happened before. All right? Okay. Origins of pay-for-performance, the short version of history here. Okay. In the 1990s, the historical rates of healthcare, at least the insurance premium growth, came down radically. It was really only one time in history experience. It seemed that the cost problem seemed to be coming under control, but that raised the concerns about quality, access, limits on access to specialist visits, tests, hospitals, and et cetera. The payment method of the decade was capitation. That was the sexy thing that everybody was doing and studying and talking about, and all of us made a lot of good money giving speeches about how to do capitation. But that then clearly capitation rewards cost moderation. It doesn't reward quality improvement per se. Neither does fee-for-service, but whatever. And so pay-for-performance to some extent came out of that, especially in California, came out as part of the backlash against managed care and the desire to reward quality improvement and not just cost moderation. Then it was so successful that the backlash against managed care, which the healthcare insurance premiums took off again. As you know, in the past decade, they have risen very dramatically to the effect that the entire growth in labor productivity, multi-factor productivity in the U.S. economy since 2000 has gone to increases for the worker wage side, increases in health insurance premium contributions. There's been no inflation-adjusted increase in average wages, average earnings for the American worker because those funds have gone into the benefit design, okay, the benefit package. So now America clearly is back to concerns about cost and about, therefore, efficiency and value, and I'll try to define those terms a little bit as we go along. Those are the buzzwords of the moment, okay? So we're all about that stuff. So anyway, we're very proud of pay-for-performance. This is what it was. Modest bonus linked to quality when the biggest problems in healthcare have been cost, because that drove the uninsured and access. This bonus was laid on top of a dysfunctional payment system, fee-for-service or capitation. It was doled out to either fragmented physician practices or over-consolidated systems, and emphasized individual providers and facilities when the real problems are lack of coordination. Aside from that, it's been a great success. All right, so we're very proud of what we've done, and I think the pay-for-performance spirit has seized the imagination of Medicare and of all right-thinking economists everywhere. Okay. All right, second generation, which is kind of where we are today. The focus extending it from quality to include efficiency. Efficiency is a very slippery term. People use that very differently. My salary is your view of inefficiency, whatever. The episode of care appears to be the natural unit of measurement, improvement, and payment. Now, what's the episode of care? The concept is that much of medicine happens to patients in something that could be defined as an episode. They get sick, they go through various treatments, they go to these providers, they may or may not go to a facility, then they may or may not have something, and then it's kind of over. It's sort of now, parts of healthcare don't fit that. A vaccination doesn't fit that. Vaccination isn't an episode of care. It's an acute thing. Boom, you go in, you get the shot, you're done, you're out of there. All right. And on the other end of the spectrum, so chronic conditions don't fit the episode. They who knows when they start, but they often last forever. Okay. Although even then they will often have flare-ups, so that. But the concept is that the episode of care is a good way of thinking about healthcare, because then you can kind of wrap your arms around it, and for a variety of reasons you can improve it. See, that's what think of how Toyota does its work. What makes Toyota a good car company? They break down their production process. They don't say, we make cars. They say, no, we have processes And we break those down analytically so we can find out how to improve them at each point along the line. We do them separately. We analyze our different car lines separately. We do it and we break it down by process analysis. Process analysis and improvement is the fundamental way that manufacturing and service systems improve. Okay, this is the basic concept. And so if you want healthcare to improve, you've got to break it down into processes and not either think about it as little bits of each doctor visit as a separate thing, nor as a global, capitated, all population-based glop of stuff. Because then it's either too little or too small. So the idea is the episode of care is an analytic way of thinking about it that can be that middle ground. And if you want to read something about that, I mean, some of the recent books that have really promoted that, Redefining Healthcare by Michael Porter and Theisberg, or Hal Luff's new book, Total Cure, and President Obama, the usual suspects, like this kind of stuff, all right? So, and the episode of care has multiple uses, and we'll talk about it. So, and it's important which different use, but one use of measurement using the episode is feedback to the providers, to the physicians, to the hospitals, to the other caregivers on the whole course of care, all right? Let's just take a really simple example, hip replacement surgery. Okay? It is really lame to give feedback to the surgeon separately from the rest of the system. Okay? Because often what happens is the surgeon may be doing a good job or not so good job, but what about the pre-surgical workup? What about the post-surgical care, post-discharge care, PT, SNF, all that stuff that really is a whole bundle of care, and really what we care from the patient's point of view. It's not how one part of my procedure went, but the whole thing. Okay? It's like that old thing, the operation was a success, but the patient died, okay? Or as the Institute of Medicine and the Quality Chasm report said, that a lot of the problems of quality are not that any one person is doing the wrong thing or doing something inappropriately, but that the patient falls through the gaps. It's the handoffs, the trade-offs, the coordination that's the problem. So the first use is feedback to the providers. A second potential use is quality reporting to the patients, public reporting. Clearly, like for quality purposes, you do care about the whole episode. You don't just care about the individual component of the episode. Right? Third, the health plans are interested potentially in doing contracting with providers around episodes. This is used most often in Center of Excellence contracting at the quaternary level with a solid organ transplant. The health plans usually have networks of a limited number of major medical centers that they channel their patients that need liver transplant or heart. And there it tends to be a case rate, all-in product, and they only will contract for those services with certain facilities and not with other facilities. And so the idea is there's the bundle, the pre-op, the post-op, the whole thing, all in, boom. Okay. Fourthly, and what gets a lot of the chat, is payment methods. And the best way to think about a bundled payment method is just the DRG system. The DRG is a really crude, first-generation, truncated, but all in all, pretty successful payment method. Right? Basically says that the episode is from admission to discharge. That's a really stupid way to define an episode, but it kind of works for a lot of reasons. And then what we're bundled in is everything that the hospital does except for the doctors, which is also really lame. Could you imagine if Toyota didn't bundle in the engineers into their price of the car? You bought a car, but you also then had to pay the engineer separately. You could just imagine. But anyway, still DRGs, I've got a lot of respect for the DRG system. It's survived the test of time, and we're now kind of talking about extending it rather than scrapping it. And then the final potential use that we've engaged in is the basis for measuring efficiency under either gain sharing or pay-for-performance programs. The idea being, if you want to say that someone's efficient, what are they efficient at? Once again, you want it to be efficient at the whole episode of care. You don't want them to just sort of to become very efficient at some component and then have it balloon out over here, right? Or something like that. It's really the whole process of care, and the hope is that by process analysis you can really encourage real systemic changes, because I guess our way of thinking about this is the strategy of moderating healthcare cost growth by paying providers less is a short-term, absolutely destined to fail strategy unless the providers are given tools to reduce their underlying rate of cost growth. Because otherwise you're just putting a lid on a pot, and the fire's boiling, the water's boiling, and we knew that's what happened, you know, if you want to think about it, in the 90s. For various reasons we managed to put a lid on the pot for a few years, and then it just blew off. Okay, and then costs just went right back up again. Right? So that's what we want to give the providers. That's what it's all about. It's giving helping the health plans, I mean the doctors and the hospitals moderate their costs. Okay, a little bit of words on California. The California model of pay-for-performance is sort of a three-layer cake. The health plan pays the medical group, and the medical group pays the doctor. The health plan doesn't pay the doctor. Right? That's because, for various historical and cultural reasons, there are a lot of medical groups in California, and they play a larger role in the overall ecology of the healthcare delivery system in California than they do in most other parts of the country. The other area of the country that has a very large medical group component, of course, is the upper Midwest, basically the Mayo Clinic world, and all of its spin-offs and offshoots and all of that. Down in most cities have a few prominent multi-specialty clinics like Kelsey-Seybold or something of that nature, but most of America, of course, is with small physician practices, and which this doesn't apply to. Okay, so performance is measured and rewarded at the level of the medical group, not the individual doctor. All the insurers use the same measures. This was the big thing. Every insurance company wanted to have its own measures of quality and performance, drove the providers absolutely nuts. They were supposed to gather different kinds of data, submit it in different ways. Then also all the insurers would pool their data so that we could have more robust numbers, because otherwise the physicians were finding that they had 7 patients from Aetna and they were getting evaluated by Aetna. And it's like, well, what does that mean? What does 7 patients mean, or what can we do with that? Or they would say, Aetna would say, you're good, and then United would say, no, you're bad on these measures, on our measures. And they go, what does that mean? How's that possible? I don't treat these patients differently. What it is small numbers problems, and it's variability, and so let's pool the data and say that the medical group is good or bad for all of its patients on average. Okay? So actually has a single scorecard for each medical group, not multiple scorecards by health plan. And the insurers then base their pay-for-performance bonus on the performance across all the patients, but each decides how much they want to pay. Even for purely antitrust reasons, you couldn't get the insurers together and say, well, let's all pay X number of dollars per, if you hit this threshold for this indicator of quality, we'll give you X number of dollars. You couldn't come together on that. The antitrust people would certainly not let you do that, and the insurance companies wouldn't want to do that anyway, because they are competing with one another and whatever. Okay. Now, this has got certain disadvantages and certain advantages, and I'll just briefly talk about the advantages. First and foremost, using a medical group model as opposed to an individual physician as the unit of analysis. First and foremost is that the measurement is more robust. Medical groups, by definition, have more patients than do individual physicians, and so you simply have more data to get statistically reliable estimates of what you're looking at. Okay? And the wonderful thing about most people is that most people are very healthy most of the time. So that means they're not generating any good healthcare claims data at all. And so you need to amalgamate the data. Secondly, performance, and you want quality or efficiency or whatever, often is not something that's caused by an individual physician. It's caused by the group of all the people who touch the patient. There may be multiple physicians, depending on the illness and how severe and how long. Multiple physicians, nurses, different facilities. The patient may be going inpatient, outpatient, being in a SNF. That's what influences quality. That's what drives quality, not just the acts of the individuals, although of course they count. Right? Attribution of importance to causality, which is very important in pay-for-performance, is easier at the medical group level, because the problem is if at the individual level, so the patient has a lousy outcome, or let's say not even an outcome. Let's say the diabetic patient, they're not getting their blood, the hemoglobin is not under control. Okay, now that's the most easy P4Performance. I mean, every P4P program in the country is targeting hemoglobin A1C levels. I mean, just every single one. And so the patient's not in compliance. Well, whose fault is that? Okay? Is it the primary care physician or whatever? That's the usual thing, to ding the doctor. All right? But no, realistically, you know, this patient's probably seeing multiple providers. It's driven by behavioral factors. If it's a severe case, the patient may be in and out of facilities doing various things. So to say that we're going to ding the individual doctors is tough, particularly in more complicated cases, you know, where there's a lot of people working together. You know, as the data from Dartmouth have shown, that particularly for Medicare patients, most patients with a chronic condition, they'll see, I think the average is 15 different providers over the course of a year. Something like that. I think that's the number. Anyway, a large number of people. And so to try to say, no, it's your fault, no, it's not your fault, you know, it's ridiculous in our view. You know, it's all together. You're all in. It's kind of like at the university. It's not like Professor Robinson is good, but Berkeley's bad. No, it's not good. You know, we're all in. Everybody's in. Okay. We pool data to reduce random variation, and also medical groups can respond to a single set of incentives, because otherwise they were getting like one bonus program from Aetna, and then there's WellPoint, and then there's HealthNet, and they're all kind of measuring different things. And after a while, you know, not after a while, right away, the doctors and the medical groups are just not paying attention to anything. And then there's just a minor statistical thing. What we're talking about here is the HMO product, which in California, different once again from the rest of the country, is the dominant product still. And the HMO benefit design, by which I mean levels of cost sharing, is very regulated, and it's very rich, and it's very standardized. So that the differences in what patients do and whether they seek care and et cetera isn't driven, the variation in what I'm going to be talking about, by their benefit design. This is hugely different than in the PPO product. The PPO product is mainly a product which its variation is by benefit design. And so patients face very different levels of deductibles, co-payments, co-insurance. And so the kind of health care that they utilize is heavily influenced by their benefit design. And you need to know what their benefit design is if you want to say, well, this patient did this and that patient did that, and they were different. Why? You need to know what their benefit design is. But in the HMO product, you don't, because they've got the same benefit design. You can focus on other things. Okay. All right, just briefly on our experience. It's the largest in the country. They paid out $260-odd million in the past 5 years. The participants are the 6 major non-Kaiser insurers. Kaiser is its own system there. Kaiser is very big in California. With about 7 million people, I believe, in there. But there's another 7 million enrollees across 230 medical groups up and down the state. About 40 measures are measured. They're process and outcome measures of quality, self-assessed measures of patient satisfaction and patient access to care as assessed by the patient, and the adoption of various components of interoperable clinical information technology at the medical group level. Impact, hard to measure, but all in all, very modest. Okay, none of this stuff is, there's no breakthroughs on anything in this world. Very hard to influence behavior. And in the meantime, what's been going on is that the big facts in the healthcare system in California, as well as everywhere else, the big story is the resurgence of costs. And with the resurgence of costs comes the rapid decline in employment-based and commercial health insurance. The effects of that have been moderated, very importantly, by a rapid expansion in the Medicaid program during this time period, but nevertheless a serious decline in the commercially based insured, and that growth that does exist in the commercially insured population is in high deductible PPO products. There is no high deductible HMO products because the regulators will not permit that. But in the PPO product, this is what, particularly in the small and individual market, the fastest growing sales are. Fastest growing products in the California market, probably Texas too, is the $2,500 deductible. The fastest growing in the individual market excludes maternity care. These are products that come in, they're thin products. The people are insured, but they, in order to keep the premium down, they just have a lot of cost sharing. Okay, and it's all the way through. It's pharmacy co-insurance without an out-of-pocket maximum. It's a whole series of things of this nature that are very designed to keep down the premium, and that's what people are buying. because of the premium. Okay. Now, in sort of the evolution of payment, we could talk about most payment systems is basically, we call it pay for quantity. Fee for service, the more you do, the more you get paid. And capitation is really the same thing. The more patients you can manage in your panel, the more you get paid. Then first generation pay for performance was really pay for quality. In addition to that, and now we're trying to talk about pay for value, which means both quality and efficiency. Problems are, how do you conceptualize efficiency? Is it utilization? Is it expenditures? We'll talk about that later. How do you measure it? Is it going to be measured on the episode basis or so-called population-based measures? We'll talk about that. And how do you reward it? What's this? Is it like a P for P bonus thing? Is it a gain-sharing model? Is it something else? Okay? As I said earlier, the episode of care is all the rage. All right-thinking people believe that the episode of care is the solution to all of our problems. And the best way to think about the episode is expanding the DRG to include the physician component and the post-discharge component. That is what is proposed by MedPAC. That is the ACE demonstration projects being run in Texas and in Oklahoma and Colorado around orthopedic surgery and interventional cardiology. We are doing those kinds of things ourselves. There's a variety of people who have advocated the extension of episode payment to the commercially insured population. If you hang out in health policy land, you'll have heard of the Prometheus grouper. The Commonwealth Fund is unflagging a booster of this. Like I said, Hal Luft's book, Mike Porter's book, a lot of good thinking. The stuff dates actually way back. There's, and actually, if you really wanted to be scholarly about this, you would say, if the episode of care is such a good, an episode payment, bundle payment, case rate, the whole deal, is such a good idea, how come it hasn't been implemented? Okay, how come, I mean, episode payment has failed the market test for the past 30 years. Okay? Why don't the commercial insurers use it? No one's preventing them from using it. Why don't the providers demand it, et cetera. We could spend the afternoon, if we wanted, talking about failed attempts to use the episode payment and episode care, Oxford Healthcare, the CMS Cabbage demonstration project, a lot of the startups that I know from the California world that tried to take this nationally. A lot of venture capital money was lost in this. All right? The key issues are data, attribution, and organizational. The key issues are not conceptual. I've never heard anyone say anything at the conceptual level that the episode of care, the episode of illness, is not a good way to think about, measure, and reward health care. I mean, I've never heard of a good argument against it at the conceptual level. All the problems are at the really nitty-gritty, boring, stupid level, okay? But that's healthcare, all right? Okay, so a couple years ago, IHA board, we decided that the big issue was cost, frankly, the lack of affordability that was driving enrollment out of this, and so all this focus is sort of overemphasis on, not overemphasis, but a single-minded emphasis on quality was like rearranging decks on, chairs on the Titanic deck or whatever. So we decided to try to include efficiency as well as quality in the P4P program. The idea is that would be public reporting. That's all managed by the state government. They run the whole we collect the data, they publish it. The idea is medical groups will use their own performance data compared against benchmarks, which they can get from us, to improve. That's the real hope. That's the real solution. And that the reward for efficiency will not be a bonus. I mean, remember how quality-based P4P works. The insurers have contracts with the providers, either fee for service or it's capitation or whatever. Let's say I'm an insurance company, you're a doctor. I pay you at a contracted rate. Then we also have this program over here called P4P. If you achieve certain thresholds of quality as defined on these metrics, I pay you even more. Okay, that's the deal. All right? It's an incentive for you to do better. Well, on efficiency, we ain't going to do that. We want to pay you less. That's the whole point. That's the whole point. Okay? So this isn't going to be structured as a bonus. It's going to be structured as gain sharing. The idea is going to be we're going to measure your efficiency. Hopefully we can measure it validly this year. We'll measure it again next year. If you have reduced your improved your efficiency, reduced your costs, we will split that with you in different ways. Okay? Right now, if you reduce, I mean, traditionally, especially on the fee-for-service, if you reduce your costs, we keep it. Right? You know, you find a way to you know, so you're, let's say in the primary care level, you do more care over the phone and over the email. You get your doctors all on email communicating with their patients, so there's fewer walk-in visits. Great, we pay you less. We don't pay you for those visits because they didn't happen. Right? So we're the insurance company, and so you're the, you know, or you decide that you develop protocols. You don't need quite as many MRIs. Not every headache is a brain tumor, probably, right? So fine, we pay for less MRIs. We love you, baby. We keep it. All right. Bigger bonus for our CEO, not for your CEO. Okay. So anyway, let's split it. Now, so IHA contracted with, there's really, you have to use groupers. When you want to use episodes, you have to have groupers. Groupers are a software that says, looking at these streams of claims data and say, okay, all these claims we're going to call are part of an episode, and the other claims are not. Okay, so once again, easy example, knee replacement surgery. If it's a diagnostic test related to the knee, it's in. If the patient has got knee problems and severe arthritis and seeing that, but also has diabetes, well, those claims, they're out. We'll pay them other, you know what I mean? They're not bundled. They're paid by, you know, however we're paying them. Either capitation or, you know, or fee for service or whatever. But everything, you know, we've got everything that's the knee, the surgeon, the anesthesiologist, the facility, the post-discharge, the home health, the PT, you know, there's this stream of claims that come by. That's what insurance is. Streams of claims that come by, and it plucks things out of that stream and says, okay, we're going to put them over here into this bundle, and we're going to pay you one price for that bundle, but we have to pluck everything out of the claim stream. We don't want to pay you twice. Okay? That's actually paying providers twice is a violation of the Hippocratic Oath of insurance. All right? So that ain't going to happen. All right? There's basically two commercial groupers out there. The MEG, a medical episode grouper, is managed by Thomson MedStat. The other one is ETGs, run by Ingenix, which is a United Health Group subsidiary. The MEG grouper is basically based around diagnoses, not procedures. ETGs is more of a procedure-based grouper. Prometheus is a new grouper out there, which is a little bit more also a diagnostic-based grouper. You adjust these things for severity within the episode and for comorbidities outside the episode. And what I'm going to talk about here today are experiences based on a test year. What we did is, we always have to do, is get a bunch of data and analyze and see whether, you know, what if we did it like this, what would it be like? And so we got 6 of the HMO products, which together had 5 million enrollees in 2006, give us all their data for those 5 million patients, and that's their, you know, the professional, in other words, physician data, hospital, drug, ambulatory surgery. All right, and so then I want to talk about the 4 challenges that we ran into. But actually, I want to pause for just a second because I've been just kind of blasting through this. Any questions or comments so far just on the concept of pay for performance and efficiency measurement within pay for performance, or episode as a unit of doing any of this?
How would you treat pregnancy?
Okay, pregnancy, good example. The insurers wouldn't treat pregnancy. They would treat maternity. Okay, I mean, maternity services. Maternity services is in some ways a natural episode grouper. I mean, natural episode, because right now there's payments for the prenatal care. They go wherever that goes, and then for the physician gets paid on a fee-for-service basis over here. The hospital gets paid over there. Any answer, it's all kind of, so the idea would be, and there would say, okay, we're going to have a bundled payment, and we're going to say that the hospital, let's call it the hospital physician system, let's just say they're together on this, will give us a price of, plucking a number, $10,000 all in. Okay, that includes the prenatal, that includes the actual delivery, that includes whatever post-delivery, post-discharge care. There would have to be a rider for what happens if it was a C-section, or, you know what I mean? There'd have to be some severity issues, but that would be the way it would work, yes.
Does that include the infant as well?
The care for the infant, you mean? The care for the infant? It could be done either way. Typically, I mean, I don't design these things, so I'm not the right person to ask. You could ask Meg or ETG how they do it. My guess is no. They would have a separate payment because the economics of the infant are very different from the economics of the mother. Okay, most infants are extremely cheap, and a few of them are really expensive in their first 30 days of life, or however you want to call it. Yes, sir.
How do you define who's in the medical group model? Is it all single specialty? Is it a multi-specialty model? And if so, is it geographic or what? Okay.
So the question was, well, who defines the medical group that's going to be receiving this? And I guess there's two questions. One is, how are medical groups in California structured? And then how might you structure them elsewhere? In California, they're structured by self-selection. The group is whoever wants, it's a business, and they form themselves. They're out there. Okay, some of them are what I would call staff model, by which we mean the doctors are employees and they're paid a salary. They may also own the group, but they're full-time, they work at the group. It's like Kelsey-Seybold, it's like Mayo Clinic. And others are IPA, or Independent Practice Association models, where the medical group, is really just a contracting shell, which contracts with the health plans. And then underneath them, if you want to use that kind of underneath language, are all the doctor practices, which may be a solo practice, they may be small group practice, and they may be fairly big practices. But they all together, they come together through the IPA to contract with the health plans. And here in Houston, you saw that, I don't know how prevalent they are still today, North American Medical Management, very big in the Houston area, back in the heyday, that's what they would do. Okay, so there's about 230 or 250 of them in California. They range from small to large, and how you measure them in an HMO product is how many patients do they have? Because there's capitation, they all have primary care physicians. They're all multi-specialty. They all have to have the full range of primary to specialty, except for sub-specialists. They will outsource, transplant, and that they'll go to the academic medical center, wherever they're going to go. But for all the normal specialists, they'll be in the group. And I'm sorry, I lost track of my conversation of where I was going with that. But anyway, that would be the entity. The advantage of that is when you're going to bundle pricing is where do you send the dollar? Okay? Right now, we send the dollar to the doctor, and a dollar to the hospital, and a dollar to the physical therapist, and you know what I mean? Under bundle payment, no, you send a dollar to one entity, which then has to divide it, and that's a big problem. Who's that entity going to be? Okay? All right. Okay, I'm going to blast through along this because I'm getting from my boss down there. Okay, we have 4 problems, and this is going to nitty-gritty, so I'll just blast through this with actually using this. Attribution. Okay, first of all, attribution in California is not a big issue because we say that the group is responsible for the episode, and the group provides almost all the services, and so it's not like, wait a minute, I'm being blamed for something else. If you try to do this in the more prevalent area where the doctors are in small group practice, and so multiple different doctors and let's just say doctors and facilities, et cetera, are treating the same patient, to figure out who's responsible, where do you send the money, if there's good quality or bad quality, who did it, is a big challenge. Okay? But less so in California. We have other problems. Small numbers of patients per episode. In order to have statistically valid measurement at the level of the episode, you have to have enough patients. We pick 30 patients per episode as an arbitrary, in order to say what's the average performance of this medical group for this episode, they've got to have 30 patients in the year that had that episode. Well, I don't know if that sounds like a big number or a small number to you, but by the time there's 570 types of episode groups, and most patients have 0 because they're healthy. Okay, so you don't have enough patients, even at the group level, to have valid measures at the episode level of very many things. Okay, even pooling data across 5 million patients. okay? Because you certainly don't want to split it by insurance company, okay? And these medical groups range from, let's say, from 100 HMO patients to 350,000, okay? Now, if they only have 100 HMO patients, it means that they've got a lot of PPO patients or something. It's not as if they don't treat hardly any people. It's just that they don't have many patients that are involved in this study, okay? And only 75 of the types of episodes could be validly used for even half the groups, and only 28 for even 2/3 of the groups. This is actually a very devastating finding. I mean, I don't know if this is surprising or not, but it means that even at the medical group level, you can't say whether this group is more efficient than the average or more efficient than that group for most types of things that healthcare happens. Okay? Yeah.
How many medical groups are there?
230. Okay? At the individual doctor level, you can forget it altogether. You can't measure, you can't validly measure quality, even for diabetes care. This was a study, great study published in JAMA about a decade ago. I think it was data out of the medical outcome study saying even for diabetes, the #1 most prevalent chronic condition in America, primary care, no primary care physician sees enough diabetes to be actually statistically validly measured and compared against the others because of the confidence intervals are too large. Okay? So all those reports about best doctor in America, yeah.
How correlated is performance across the episodes? Can you use a subset of the episodes to proxy for the others?
We didn't look at that. And presumably they would, I could think of examples going both ways, you know. But anyway, but there were some of the ones at the medical group level for the big ones, hypertension, diabetes. Yes, there's enough data. There's enough you can actually do it at the medical group level, not at the individual doctor level. Okay. Next is incompleteness of the claims data. How good are these data? I mean, like, what's on these data? And without getting into the nitty-gritty of it, the more you look, the less you like it, okay, in terms of how much is coded, especially diagnostic coding. Procedures tend to be better coded because doctors get paid for procedures. They don't get paid for diagnoses. Yet procedures are very important if you're trying to group people by episodes that are based around diagnoses, like diabetes. If the episode is based around a procedure, like hip replacement, then, because they get paid for that, so it's better on there. Also, secondary diagnosis, terrible coding, okay? And these, we're not talking about, your little community-based health plan here, okay? Aetna, United, WellPoint, HealthNet, these are the companies that we're talking about. These are our companies. Okay, and these are their best data, and I'm not beating on the insurance companies. I'm just saying because it's not the insurance companies actually. It's the providers that that submit this stuff or don't. Then actualized versus standardized prices. This is kind of a very nitty-gritty thing too, conceptually. Utilization. If you're efficient, does that mean that you have less use of resources? Is that a utilization measure? Or is it a cost measure? You spend less per patient, per year, per whatever. Because the difference between those is cost is utilization times price, times unit price. Okay? And what you find is sometimes provider organizations that can bring down their utilization because they manage the stuff very well, they're very consolidated and they bargain for very high prices. Okay? We always have fun in California because the Dartmouth people have come to California and they've looked at all the variation and all the stupidity, and they've identified the most efficient market in California, probably in the country, is Sacramento. Because the managed care is really heavy duty there. They've got inpatient utilization down, real down. It's all very integrated. They've really got it down. But it's also one hell of a consolidated market, and they have the highest unit prices in the state. So the insurance companies are going, yeah, they're doing less, but we're paying them more. Okay? So how do we think about that? And as a practical purposes, the hospitals and stuff just refuse to let us use real prices. It's like, forget it. So we use so-called standardized prices, and then we all measured utilization, efficiency based on utilization. But the insurers, and behind them, the Pacific Business Group on Health, which is part of what we do and represents sort of the large corporate type employers, they're kind of going, I care about the dollars. You know what I mean? If you tell me that they're using less resources, but they're charging me so much more, that's fine, but at the end of the day, I care about how much am I paying, because I'm a payer. You know, this is a huge issue, an absolutely huge issue in the real world. And there's contracts out there which just refuse that you cannot use real prices, period. As we say, price transparency is for others, okay? You know, the hospitals want the medical device company prices to be transparent but not their own. The insurance companies want the hospital prices to be transparent but not their own, etc. I'll just skip right over that in the interest of time. So where does that leave the IHA? They've actually backtracked away from using the episode as the unit of measurement for efficiency, still interested in efficiency, but use so-called population-based terms, which is things like, and the ones that we're going to use, and I'll just skip right to it, hospital admissions, non-maternity, per 1,000 enrollees. That's a good old-fashioned managed care measure. Ambulatory surgery procedures as a percentage of total, the ones that are done in a freestanding ambulatory surgery as opposed to those done in a hospital outpatient department. This is the kind of stuff that drives all of you all crazy. They're all trying to, all those physician-owned ambulatory surgery centers are trying to pull the patients out of the hospital-based ambulatory surgery centers, and the insurers say, yeah, but look, the hospital-based things, the unit prices are twice. 3 times what they pay in the ambulatory surgery. Generic drugs as a percent of total drugs. Readmissions, that's a very sexy one today. We're trying to reduce readmissions, obviously. And ED visits as per 1,000 enrollees. Once again, trying to reduce ED visits. The goal of this whole thing, of course, is to, this whole California managed care thing, the idea is to promote better access to primary and urgent care and get the people should not be in the emergency room. That's not where they should be treated. Okay, so now I want to just wrap up and say where is this going just in terms of the national interest, and if you follow this payment discussion, you are all keen on this concept that bundle payment is what everybody's talking about, and it's a good thing. I personally think it's a good thing. And what did we learn? What's the implications of this experience? First of all, the episode of care as a unit of payment is not plagued by some of the same problems that we've been talking about as a unit of measurement for either quality measurement or for efficiency measurement, for the following reason. Basically, what an episode-based, case rate-based payment mechanism would look like is just think DRGs. The DRG system, CMS and all of its contractors, have to figure out what's the relative weight of every DRG compared to every other DRG. That analysis requires massive claims data from many hospitals and zillions of admissions for each of those, and they've got to have enough patients in each of those DRGs to come up with the valid weights. Ditto for the RBRVS physician fee schedule. Right? You need a lot of data. But then once you put dollars, you put a dollar conversion factor onto that, then they say, this is what we're going to pay for this DRG. You have a patient with this DRG, this is what you get. You're the hospital. It doesn't matter how many patients you have in that DRG. You have 1 patient this year, that's what you get. You have 100 patients with that DRG this year, you get 100 times that. Okay? We don't care. You know, there's outliers. There's a little bit of complications. If you're a wonk, you kind of start worrying about certain things. But all in all, you don't need to have 30 patients per DRG type to get paid validly under DRGs. Okay? Nor would you need it under a bundle payment thing. Okay? So where are we going with that? Let's just, not that you care about IHA particularly, but so we're saying pay for performance is going to be about quality, and it's going to be about efficiency measured in these days per 1,000, visits per 1,000, generic drug stuff, which is nothing to do with an episode there. There's no episode there. And then where episodes is going to land is going to be on the other side of our brain, is that we're piloting a bundle payment methods, somewhat following the same principles as the CMS demonstration project in our own commercially insured population, not Medicare. But only around certain, just very experimental, just around certain parts of healthcare which clearly seem to follow an episode logic. And those are really orthopedic surgery and interventional cardiology, where it's, even though there's underlying chronic conditions like osteoarthritis, nevertheless, you can kind of say, okay, hip replacement, yeah, that's got a beginning, a middle, and an end. You know, we can kind of put a bundle around that. Or, angioplasty with drug-eluting stent. Yes, the underlying conditions are, atherosclerosis and whatever, but still, we can say that, it's got a diagnosis, a workup, the patient goes into the cath lab, the thing happens to the patient, they're discharged, boom, that's the bundle. And CRM, cardiac rhythm management, pacemaker, defibrillator. It's a big ticket, medical device intensive, because I work on medical device stuff. And so the debates, when you get into this, though, beyond that is how inclusive is the episode, how much post-discharge, how far out do you go after the, let's say after the knee replacement? Is it a 30-day window? Is it a 60, 180-day window? Huge implications, okay? How do you adjust for severity? How do you adjust for severity, number one? And next thing, how do you adjust for appropriateness? You don't want to incentivize the system to be really efficient at unnecessary procedures, okay? And like when you look at, like, say, a lot of what we're working on is spine surgery. Now, spine surgery, lumbar and cervical fusion are big procedures for us, but the variation and the indications for that are all over the map. And depending on who you talk to, we have an epidemic of overuse or an epidemic of underuse of spine surgery in America. All right, and quality. To whom is the payment made? We've we've discussed that. And then is it budget neutral? Are we going to pay we, the insurers? I shouldn't say we. I mean, I'm not an insurer. I don't work for insurers. I don't pay anybody. That's part of my Hippocratic oath. But how are the insurers going to pay the providers the same next year on a bundle payment that they would have gotten paid had they stayed with fee-for-service, say? Or are they going to say, no, now that you've got a bundle payment, you're going to be more efficient, and we're going to cut you? Okay? Medicare, of course, cuts you. All right? And that's why, and unfortunately, the history of bundle payment, one of the reasons it's failed is that every time people try to do it, they say, oh, it's an incentive for you to reduce your costs now, so of course we're gonna take 5% or 10% right off the top. And the doctors are going, wait a minute, I call that a pay cut. I call that a pay cut, and so I'm against pay cuts, and so no. All right? And if you remember DRG implementation, one of the key things was it was budget neutral. And so anyway, that's a question that we're all wrestling with. And then as far as efficiency, like I say, and this I guess is my last slide. What is it? Wait, I say all payment is pay for performance. The only question is which kind of performance is being paid for, is being rewarded. That's the, so it's not, pay for performance is not a new concept. Traditional forms of payment are basically like fee for service motivates productivity. The more you do, the more you get paid. Good method of paying doctors if you want them to work hard. I got nothing against that. Pay for quality improves data and quality. I mean, the best thing that's happened out of P4P in California is the data have improved. The quality data, the measurement of the quality data has improved. Okay. Gain sharing motivates efficiency. It does. How to motivate appropriateness? That's a tricky one, very tricky one. Okay, and if you believe that the American healthcare system has got equal severe problems with overuse and underuse at the same time, which is, I guess, my worldview, how you deal with that is, and how you measure that. And then in all payment methods, simplicity is a virtue. If you look at the economist's role, they will design payment methods which are so perfect and so complicated that the doctors can't understand them, the insurers can't implement them, and the patients think it's all, fraud and abuse. All right? Okay, and then in terms of the episode of care, like I say, I still remain optimistic that I'm not optimistic, but a believer that the episode of care is the right way to break down the healthcare system into bite-sized chunks that are meaningful. They're clinically meaningful, and then they're also meaningful from a business perspective, call them service lines or whatever, and then as a unit of payment and a unit of measurement for quality reporting. But how we do that is we have to be very judicious with attention to these issues of the quantity of the data, in other words, sample size, the quality of the data, particularly appropriateness, and the attribution of the data and the payment. To whom do we assign responsibility, and to whom do we give the money? Okay. So that's my story on our experience, and I have got actually 3 minutes to go according to the clock that's on my desk. And so we've got
we have time for 3 questions. I apologize, I have to keep us on schedule because I promised all my speakers that we'd have time so they can make their flight. So 3 questions.
Back in the back, sir.
Thank you. Richard Dunn from Texas A&M. We have 2 stylized facts about health expenditures. One is that there's a big chunk at zero and it's heavily skewed off the right. And the second fact is we spend 25 to 33% of
all lifetime health expenditures at the end of life. So how do we treat the last episode of care in PayforPerformance?
Well, I don't think that PayforPerformance is a solution to every problem. I do think that the skewness of healthcare expenditures, which you refer to, is very important, is an argument in favor of episode pricing for certain things. Because even if lots of healthcare it doesn't sort of feel like it fits the episode model, a lot of where the big dollars are do. You know, it's like the problem is osteoarthritis, but the dollars are hip replacement. And if we can we can wrap a payment method around the acute manifestations of underlying chronic conditions, we can make a lot more progress than if we just say it's diabetes, because then it's kind of like it's everything goes. That's not a real answer to your question, but a partial. Sir.
Yes, I assume that in the episode of care, you include the provision of preventive medicine by the physician.
Provision of which medicine? I'm sorry.
Preventive care.
Preventive medicine. It depends on how you define the episode. Generally, we would say you could have episode pricing lends itself to certain kinds of preventive care and not others. What kind of that would do is, like, for example, in pediatrics, they like to have bundle payment for all the vaccinations that the doctor's going to give and give them a one or well baby care. For something like osteoarthritis, it would be very hard to bundle that in because most of the people with arthritis don't have knee replacement. And so to try to make an episode that was sufficiently elastic.
Yeah, but the point is that there is no incentive for the patient or incentive for the physician in the modification of health styles.
Right,
if I, as a physician, recommend to the diabetic exercise, diet, etc., and the patient complies, somehow this should be rewarded for the patient and for the physician.
Totally.
And I did not see in your model that this was taken into consideration.
The current PayforPerformance program, at least as is in California, is almost all about these kinds of either primary care or preventive services. That's what's being measured, and that's what's being rewarded. It doesn't deal with specialty services much at all, and that's what we're talking about here. Episode-based payment really is not about primary and preventive care. It's not a solution for all those problems. It doesn't mean it's bad. Okay, if we could deal with cost quality in orthopedic surgery, that's a worthy thing. That doesn't mean that we don't have to also deal with primary care and prevention. But those are not going to be paid on an episode-based price. They're going to be paid either fee-for-service or some sort of a capitated basis.
When will the healthcare industry provide more energy into the assessment of health maintenance in the part of the insured? If I go for automobile insurance, if I haven't had any accidents, etc., I pay less of a premium. When will we do that for the
Well, we're just about to outlaw that for health insurance. President Obama is going to make it illegal for health insurers to base their premium on health status or health behavior or of any kind. So I think that model is not the way we're going to go. We'll have to do prevention in other ways. But prevention, clearly, if we could prevent these episodes, it's much better than treating them.
That's right.
Jamie, I'm perseverating on your small numbers problem in your California experience. You had 570 episode definitions, 228 medical groups, and less than 30 episodes per group for most of them. What do you think is the big problem? Is 570 too many, which was Kate's suggestion about proxies? Is 228 groups too many, or should we just not give a hoot about the less than 30?
I think that for bundled payment, we can forget about the less than 30. If we had our fee schedule, so to speak, our episode-based fee schedule, we don't need every group to have 30 patients. That's the saving grace for bundled payment. Now, bundled payment is only one use. Let's say we also want to measure quality, okay, and report quality for patients so they can make more informed choices of doctors and et cetera. There we do need the 30 patients. Okay, so what that says to me is that we need either bigger, not 570, but for certain purposes, amalgamate those so you have more patients. And then certain things lend themselves better, certain high volume, discrete things. Coronary artery bypass surgery, high volume, you can report that. Okay? Other things, we just kind of got to give up on this public reporting mania. Because the data are not valid. It's invalid. Most of the data that are reported by most health plans and most independent third-party things on the web or elsewhere about physician performance, including U.S. News Report, are invalid. They are invalid measures. Okay, we just got to just sort of suck that up and measure where we can, reward where we can, and there's no one solution. Okay? So on that optimistic note, I'm going to turn it back to Vivian. And what we want, I guess the last thing about the California thing is California, Texas, we're about the same, right? Big states, big geography, big population, close to Mexico, very diverse, lots of uninsured people, you know. You've got more, I don't know, gun-toting Republicans, we've got more dope-smoking Democrats, but aside from that, we're together. And so I would just picking up on what Vivian was saying earlier is we do encourage, I think that although national policy is very important, what can be done at the local level with the cultural, with the health plans and the providers and the medical groups and the hospitals at the local level is very important. So I encourage you all to work together across the physician, hospital, health plan lines and try to make these things work in Texas. Thank you.
Well, y'all come back to Texas anytime you like, Jamie. We're ready to move over to lunch. Lunch is at the Student Center.